In my opinion, there is nothing that could ever replace putting a hand on someone's shoulder while you tell them difficult news, especially news to a mom and dad that are hearing the unthinkable about their son. It seems so odd to me, too, that no one ever followed up with us in the days that followed that appointment. From that moment on, doctors kept telling us that the toughest part was still ahead. And honestly, they were right. 5 specialty areas instantly got involved because Schimke affects 5 different areas of the patient's body. And most times, that number was at a minimum. The only treatment for SIOD are for the symptoms, which are progressive, and they changed weekly. 1 week, Michael would be having hip problems, so we needed to have an orthopedic appointment. The next week, his kidney status would be failing, so we would need a nephrology appointment. Then the TIA started, many strokes started, so neurology got involved. And that's the way we started living our life with SIOD. 1 doctor visit, 1 emergency room, 1 hospitalization after another. Now, that did not include the additional consults, the follow-ups, the labs, the radiology appointments that were also in addition to those other appointments. We desperately needed coordinated care, which is a term I'm familiar with right now, but I wasn't back then. We kept experiencing each specialty care wanting to operate independent of each other, separate from each other, and in no way did that serve Michael or us as a family. This disease abruptly invaded Michael's life one day, and the rest of our life, though, continued. The world's events still continued around us. I took a leave of absence to handle getting Michael adjusted to what was changing in his life, but my husband still had to go to work. We needed the health insurance that his company provided. So he still had his work demands, which meant that at most appointments, most hospitalizations, it was me and Michael, and we were just alone and separate from our family. School activities continued. Our daughter was very involved in softball, so her softball practices, her games, those still continued. Even grocery shopping seemed difficult and challenging, along with dealing with SIOD. To me, as Michael's mother, it seemed as if one day I was buying him cleats for his t-ball team, and just a few days later, I was taking him to be fitted for a wheelchair. It seemed to speed forward that fast for me. Despite of the abrupt changes, though, Michael's life had to continue in some way in order to meet his emotional needs, which affected his medical symptoms and they affected his immune status. Because of Schimke's complexities, it was really easy to lose sight of the fact that this was not just, overwhelming to us, but it was devastating to Michael. Real coordinated care means putting home life and family life as a priority that's equal to other priorities. Illness demands respecting the fact that all of us, healthcare providers, parents, even sick children, have busy, complicated schedules, and they all are important. In our situation, along with needing more coordination in Michael's appointments, we also needed healthcare providers to make decisions as a team and communicate with each other without me insisting upon it. My hands were full, simply caring for Michael, keeping our family intact, and trying not to become the statistic they warned us about. Our pediatrician and his nurse became our really good friends. They did everything they could to get to know Michael, get to know his likes and his dislikes, get to know me, get to know our family dynamic, trying to eliminate anxiety and fears while we were at their clinic. They took the time to research the diagnosis and find out ways to put some ease into all of his appointments. Dr. B and Nurse Cindy offered a willingness to be a link to the university, which kept us close to home, kept us close to Michael's school, kept us connected as a family. They dramatically impacted our clinic experiences by their relationship with us and demonstrated coordinated care in action beyond words. Michael trusted them. So did I. Along with clinical instruction and information, patients and families need basic human understanding. Something like linking appointments together serves more than one purpose. It kept some normalcy to Michael's life, which was now completely flipped upside down and inside out. Holding on to normal supported his human self, lessening the need for third-party emotional support, such as counseling or other. Michael showed us that his best emotional support was still being able to go to Boy Scouts, was being able to ride his four-wheeler, play in his treehouse. That's the way he felt supported. That's the way he coped with this big diagnosis. We have a large spiritual community that wrapped their arms around us, but we were at the hospital so often, and so that was another challenge that we faced in trying to stay connected. Our daughter Jessica acted as a link for us most times during the times that we were at the hospital in staying connected in all those types of support through our spiritual community. So I had to do what I could to weave Michael's normal life into his SIOD life, as well as teach the medical community to do that for him too. We live in a world of tremendous medical knowledge and highly schooled individuals, but bear in mind that patients and families have tremendous knowledge and insight as well, also hard-earned and costly, just schooled and learned in a different kind of venue. Patients and families have exclusive wisdom that can enhance medical expertise in viewing the whole picture, in treating the whole person. And when we make it a part of the medical education process and daily operations, we will improve healthcare. At the beginning of this journey with Michael, I assumed that it would be the healthcare community teaching us how to do all this. Instead, it seemed as if we were consistently having to teach them, show them what was important. Now, I know that together we teach each other. At the time of Michael's diagnosis, I was no stranger to the healthcare environment and how to balance life inside a medical crisis. I was a teenager when my mom, at the age of 55, was diagnosed with gallbladder cancer, a very rare form of cancer back in the 1980s. For 7 years, my mom was fighting cancer, and I was experiencing firsthand the critical impact that important healthcare relationships have, not just on the patient, but also on the family. By it, I learned how to be a good communicator and how to be a patient advocate. I have used those skills over and over again, not just with my mom in her healthcare, but then again in my dad's healthcare, and again in our son's healthcare. Those amazing nurses and doctors educated me, and they changed me. And to this day, I still remember them. I remember those situations. You will have those kinds of opportunities. You will have those same kind of opportunities. In your role as a medical provider, you will impact and influence patients and families' lives that become their story, a health history that's not documented on paper. In patients and families' relationships where you care for medical needs as well as personal emotional needs, you create human experiences that produce an increased, more positive medical experience and makes the best possible outcome for everyone. Our son Michael is the heart and soul and inspiration for Be the Change. As a young boy, he challenged healthcare providers to treat him as a real human being, not just someone that had a rare disease. He often created situations like staying quiet with his arms crossed like this until healthcare providers would come down and talk to him face to face. He taught me how important it is, especially with pediatric patients, to come down to their level, talk to them face to face. Now, in Michael's situation with SIOD, even though he was, let's say, age 10, he looked like he was age 4. He was much smaller than his age represented. Even more important then, to treat him with respect, come down to his level. Even more important than when he started using the wheelchair, for providers to come down to his level, speak to him face to face. Michael taught us that. He became known as the little boy in the bright green wheelchair, which he didn't mind, but what he really wanted was for people to look past the wheelchair, look past the disease and just see him. Just see a boy who wanted to be normal, who had a life outside of clinics and hospitals. He was the superstar of his wheelchair basketball team. He wanted everybody to know that. He was the most popular kid at school, had the most girlfriends, he would say. He wanted people to know that about him. He loved jokes. He loved to laugh. He loved to make people laugh. That's what he wanted people to know about him. There was a situation that happened one time at his band concert. Often he had to miss all those kinds of things that he loved. He loved music. He loved really loud music. And he got to be the percussionist who was going to hit the big gong at the end of this one song. He was so excited because, of course, that would be the loudest thing that was going to happen at the band concert. The morning of the concert, I could tell when he woke up that he wasn't feeling well. He begged me, Mom, please let me go to school so I can be at the band concert. So I spoke with his school nurse. We made an arrangement that we would be checking on him, checking his temp and making sure that he was okay. And he got to go to the band concert. He got to hit the big gong, make the big noise. As his friends were going to the Dairy Queen, Michael and I were heading to the emergency room because he had spiked a fever. So you can imagine that by the time we got to the emergency room, what kind of mood he was in. The doctor who was taking care of him, of course, Michael would not talk to him. Had his hands crossed. There was going to be no way that he was going to be answering any of his questions. The doctor finally, after I told him what had happened, what we had just come from, put all his equipment down, put his notes down, put his computer down, sat on Michael's bed and said, you know, Michael, I know this really stinks. I really get that. But we're going to do whatever we can to make you better and get you home as soon as possible so you can go to the Dairy Queen with your friends very soon. So the doctor said, you know what I do with my patients who are experiencing a temperature is every time someone has to take their temp and they click off that little plastic protector thing, they link it together, and the first pediatric patient that can reach outside their door is the winner and wins a prize. Well, instantly changed. Oh, a contest. I'm going to be the winner. I'm going to be the superstar. Michael answered all his questions. Our whole experience was changed by that doctor who saw him as a boy who was frustrated and then treated his diagnosis. I began to see in many ways how healthcare providers, and me included, sometimes have had unrealistic expectations of Michael. We expected him to act like an adult, even though he wasn't. People often commented how much Michael talked like an adult, even though he was just a young teenage boy. An example of that was when Michael returned to school after his transplant. I had to go to the hospital and be with my husband, who was recovering from his heart surgery. Just as I got to the hospital, I got a call from the school nurse saying that Michael was in the office and was showing some signs of the early onset of a TIA episode. What should she do? Now, most of the time, I am never steps away from Michael's school, minutes away from him, but I needed to care for my husband as well. So after we discussed a few things and I consulted with Michael's doctors, we decided that they were going to call an ambulance. Michael was going to ride in the ambulance and I would meet them here at the university in the emergency room, since I was just about 20 minutes from here at a different hospital with my husband. So as I'm explaining this to my husband, I get another call from the school nurse who says, Michael's stable, the ambulance is here, but he told the ambulance drivers that he knows his rights and he refuses medical treatment. I thought to myself, where did he learn that? So I sped my way to the junior high school, and they stayed on the phone with me and assured me that Michael was stable. And I rode in the ambulance with Michael to the emergency room. Because of that incident, I realized that because he was constantly surrounded by medical terms in adult conversation, he naturally became adult-like. But in the truth, he was just a little boy forced to live much of his life in the adult medical world. When he should have been riding his bike or in timeout because he called his sister a dork, and trust me, that happened too, he was having MRIs, surgical procedures, kidney dialysis, and TIA episodes. Time and time again, we asked Michael to trust us, trust that we were providing the medical care that his disease required. But in order to trust us, he needed a relationship with the people taking care of him and doing things to him. Even though I was with him 98% of the time, acting on his behalf, he still needed to be in control of his own body. So regardless of his age, he had to be part of those adult healthcare conversations, which formed layers of trust, but also produced other results. Relationships build and develop trust, and with children, it's primarily done in action. I learned how necessary that was the day of that ambulance call to school. Healthcare providers, and sometimes even parents, unintentionally disrespect sick kids, sometimes because we ignore what they're saying because of their age, and also because the effects of illness, especially chronic illness and normal kid-like behavior, get all mixed together, making it very difficult to determine where one stops and the other starts. Currently, I personally think the patient, family, and provider relationship is based on more words than action. There's a lot of talk right now about patient, family-centered care. Lots of info about being a wise consumer and how to be a good patient-family advocate. But all that falls short when we fail to demonstrate that on a daily basis with each patient. We have to move the words from paper to action. Each day, with each patient, you have to make a choice. You have to make a commitment to put all your other challenges aside, giving each of your patients your whole self, making them the focus, them the center. That's what your patients have to do. They have to push everything else aside because of the disease. I found it nearly impossible some days to maintain my role as Michael's mother because I had to act in a role that was not mine. Too many times, I had to be the link between multiple specialty providers, or the nurse, or the transporter, or other things like that. I didn't mind helping, but my primary role was to be Michael's mother. And when I had to do all those different jobs, I couldn't do my job well. Statements and excuses that were made following something that went wrong or didn't go the way it should have became really frustrating, and I actually named them the blame game. It's something like, oh, pharmacy was supposed to do that, but you know, pharmacy, they have a new manager and not going so well. Oh, sorry, housekeeping was supposed to do that, and you know, right now they're really, really understaffed. Things like that and other ones like it might be true, but how do they affect the patient, their family, and your relationship with them? These kinds of excuses happened a lot, and believe me, they really do damage relationships. They diminish trust and the quality of care. I admit I don't have all the answers to those kinds of issues, but I do know in a place where the patient and family is supposed to be first, we have to work at finding more effective ways to respond. A truthful response is necessary, but make it appropriate, make it helpful. Sometimes just a sincere or a simple "I apologize" or "I'm sorry" is enough, even if it's not your fault. Sometimes you just have to say, "Can I help?" Acknowledging something changed or went wrong instead of avoiding it or pretending like it wasn't a big deal when it really was will be the beginning to mending broken hearts of angry, frustrated patients and families. I think that the patient-family and provider relationship should be a group of people centered on the patient, working together as partners towards a common goal, making every attempt to coordinate care appointments, never losing sight of all the patient-focused choices, representing that each person, regardless of age or letters following their name, bring something of value to the healthcare situation. A patient, a mother, or any family member has valuable knowledge and skills that they bring to the healthcare scenario as long as people are willing to listen to it and believe it. A critical example of this was one time when Michael was hospitalized during the dialysis phase of his care. And dialysis with a Schimke patient is very complicated and very different than just regular dialysis. A nurse and resident during that time failed to recognize the effects of fluid overload and how Schimke connected to the dialysis quickly compromised Michael's breathing. To make matters worse, they ignored what I had been telling them through the night as I watched Michael's healthcare situation decline. I had 6 months of experience in this situation already. We had already experienced 2 postponed kidney transplants because of fluid overload, because of complications to the dialysis process. What he needed was immediate dialysis, even though it was 3 a.m. As a result, Michael stopped breathing that morning, and horror followed. A code blue was called, and it was the beginning of a 2-week self-induced coma. It was a miracle that Michael survived that incident and went on to have a successful kidney transplant just 1 month later. But so much damage was done on so many levels, both physically and emotionally. My real human experience inside that medical experience, one that most people don't hear about, is I can't erase from my memory words Michael spoke to me that morning right before he stopped breathing, or the memory of watching people try to revive Michael. That's the harsh reality of a failed partnership. You as healthcare providers bring very valuable information and skills to the healthcare situation that we desperately need, but so do the patient and family. Working together accomplishes great things, which produces the best possible outcome for everyone. Individually, we cannot do what can be done in a partnership that recognizes MOM after my name or any letters like that are just as important as any other professional title. And it just might prevent a situation like I just described from ever happening again. We humanize medicine by patient-family provider relationships that are rooted in respect of each other as equal partners. The medical environment has to be sterile, but not in regards to relationships. There were times that we regretted telling the truth or giving our opinions and insights about improvements that should be made. It ranged anywhere from asking people to simply do better to asking people to protect Michael from harm, producing situations that created bad attitudes and conditional relationships, bumpy relationships. Please don't let ego, opinions, or agendas get in the way of giving patients and families the opportunity to be honest about something, to allow them to discuss with you the good, the bad, the uncomfortable, especially when it means improving care. Be open to input from patients and families. That will automatically make your role as a healthcare provider more effective, and the role of any mother, any family member, a larger asset to you. Being honest paved the way in meeting the needs of both my children, Michael and Jessica. The needs of siblings are so often overlooked in chronic illness and are another issue, and is another issue that needs some attention. Parents need a healthcare partner who is willing to look at and try to understand the patient-family dynamic. In a situation such as ours, I was more often in the medical environment and out of mine. I needed help in accomplishing healthcare goals plus our life goals. Because of SIOD, our home life was intertwined with hospital life, and we just couldn't be successful in either of them without relationships that I could trust, partners I could depend on, and then in turn, they learned I was someone they could depend on and trust too. I used to say to doctors and nurses a lot, you choose this environment. This environment might even be an extension to your home. But we didn't get to choose. Michael didn't get to choose. This is not our home.